Hello and welcome to the Auditing Antics Podcast. So today we have episode 13, Creation of Internal Compliance Policies through Cross-Department Collaboration. So today we're going to be diving into specifics related to how you come to the table with other people within your organization and making sure that everybody's on the same page and nobody's left out. And, Michelle, last time Terry and I introduced this subject and talked about it a little bit, and it's one of those things where it can be really problematic internally when you have just certain people who are wanting to either start different services or, a lot of times I find that compliance is the last to know, right? They
Yeah.
make all these decisions and then they come to you and say, why aren't we getting paid for this? And then all of a sudden we find out all of these things that have been going on.
Yeah, definitely. They they seem to do these things that are just going to be so great and it's going to improve the workflow, and then it ends up being a compliance nightmare literally. And just like you said, it seems like compliance is always the last to know. So I feel like it's really important that if you're in the position in a facility or company that you work with, you're fostering the relationships with the right people so that they know to come to you when there's any hint of things like this happening. Um, One big, EMR system that I can think of where this happens a lot is Epic.
Mhm.
Epic has these great workflows that they're going to implement, and it's going to make your life so much better. They have all these tools that are going to help, and then it's like, this did not help compliance at all. So definitely an important topic to talk about.
Yeah, and it reminds me of when we have typically providers going to conferences, for example, or different seminars. They come back, they heard about, new services, new devices, things like that. But now I'm even hearing of them coming back and saying, well, why aren't we billing for this? I listened to this physician at our conference who said that if we're doing these things, these are the codes we should be billing.
Hmm.
And, I have a lot of thoughts in general when we mix compliance and the clinical side and whether or not a physician who's out there really has the full perspective of compliance from the reimbursement side of things. There's a lot of times where I've seen that viewpoint can get skewed from the perspective of being heavy on clinical and not fully understanding what it takes to implement the services, be compliant with billing, all of those things. And I've had many situations where they come back, they think they can bill for something, they start to do it, and again, we have reimbursement issues. Now, Michelle, another thing I've seen happening quite a bit as well is, I would say, on our side, quote unquote, our side of the industry, right? Where we now have different compliance professionals, different coding professionals going out to seminars and webinars and, whatever it may be. I've talked previously, we have a lot of access to information now out there, right?
Yes.
So we're seeing it within our own group of people in the industry as well, where there's misinformation getting out there, or people are not fully understanding why somebody's saying something. And it's creating just as much of a nightmare.
Yeah, I agree. And I think that, it's something that I'm guilty of when I'm talking about a topic, in that I know in my mind what I mean, but I'm having this conversation in my mind, and what's coming out of my mouth are two different things, where pieces should be, should be included that are happening in my brain. So, when you're hearing these things that people are talking about from an educational perspective on how things should be coded or billed from a compliance perspective, always make sure that you just use that as a starting point, and then go back and do your own research. Make sure that you have an understanding of where they got that information from, because as you know, Stephanie, a lot of it is interpretation.
Mhm.
It could be simply somebody interprets something differently, and maybe they've taken a word out of context, or I've even had punctuation. Okay. Something like punctuation misunderstood or completely missed, and it changed the meaning of a sentence. I know that sounds really, really strange, but so you really got to be careful with, the things that you're hearing, and really just get in the practice of doing your own research.
Hmm.
Is what it comes down
Yeah.
to.
Well, and
Check or
even
verify.
along those same lines, you mentioned punctuation, but a lot of what we look at in compliance can come down to one word. So
Mhm.
we can have the word and, we can have the word or, we can have supposed to, required. There's
Mhm.
different things that are going to come into play when we're looking at guidelines as to whether or not it's steadfast, you've got to follow it, there's no gray area. When there are gray areas, we have to be able to come to the table and challenge that and really look at it from each perspective. And, that's one thing that I find a lot, whether I am working with my own clients or doing webinars or different conferences, things like that. Sometimes people will come up to me and they want, this roadmap that gives them specific directions on how to do something, how to implement something. And we have to remember that first, we all know the industry is constantly changing, so that adds its own challenges. But we have a lot of gray areas that we're dealing with as well. So you
Mhm.
have to understand what the risk is going to be if you choose to be more liberal in your interpretation. When you choose to be more strict and you're going to take the safe route, that is going to lessen the risk if there's an external audit. Does it mean that you have to do that? No, it's up to the organization with what they feel comfortable with, and it needs to be implemented into a policy. And that's really the part of it that is often missing when we're doing our audit work.
Mhm.
We'll have these findings and we go back and say, okay, well, this is not accurate for these reasons, and we get pushback that that's how they do it there. We obviously also hear all the time that's how we've always done it, but
Mhm.
even when they have an understanding of why they're doing it, it's kind of like the blind are leading the blind, and we don't have specific detail as to when that was looked at previously. Usually it's not written into an actual policy that can be followed, and it really creates a lot of chaos inside of an organization.
It does. And something that this makes me think about is back to when I first started coding. And I'm sure you could say this is true for yourself. And so if you're listening to this and you're somebody who's fairly new in the coding industry, or you are seasoned and you are tasked with training a new coder, how often was your education or training based on somebody's hearsay? They didn't have anything solid in front of them saying, "This is why we're telling you to do it this way." You were just doing it because this person told you to do it that way.
Or
How
how it
often
feels, how it
Yes, how
feels.
often I mean, that was my entire I can remember sitting there at my first coding job. I had banking experience. I had no clinical experience, and here I am reading these notes, and I'm like, "Oh, I don't even know what I'm doing." I passed a test. Woohoo. And here I am supposed to be coding these things, and I was kind of left to my own devices. And this one girl was supposed to check everything, and she was just like, "Okay, that's great." You know, but I nothing was given to me with any sort of like certainty. And I was just going off what people said to do. And I think that's something we need to change, and we need to see a change of in our industry. And sure, you may have many years of experience and you have a lot of knowledge, but what's backing that knowledge? Where are you getting that information from, and are you ready to share those resources? So I would challenge you to be able to share those resources. I think one way that helped me grow in that area was having to do audit rebuttals. And I hate them with a passion. But I have learned that it was a really great way for me to kind of expand on my finding and then give them the source as to why I had that finding. Um, so yeah, just a thought.
Well, and I think it's important to call out the fact that this can happen in larger
Mhm.
organizations like a hospital that has a full blown, typically coding department, separate AR or insurance team. They often have even a separate compliance team. And, this doesn't only happen in smaller practices where
Mm-mm.
you have situations of people just doing things because they were told to, and without backing and all of that. So it's important to understand that regardless of the size of your organization, there's still ways that you can look at this and tackle it and make sure that you are providing that consistency with a knowing and understanding as to why you're doing what you're doing.
Yeah, exactly.
Now, when we think about the actual process of developing a policy, it's important to know, and really the main topic in the heading of the episode is related to bringing different people to the table. So what that means is making sure that you have input not only from somebody in clinical or somebody in finance. You need to have compliance there. You also need to have, let's think about a facility for a minute. If you have a compliance department, a coding department, a separate insurance revenue team, somebody from each of those departments, whether it's a team lead or somebody in management, needs to be coming to those meetings. And, when we think about operations, it, definitely depends on who is leading an organization. If you have a COO, a lot of times I find that for sure the CFO wants to come just because of the reimbursement side of things. But we have to have all of those people there from a facility perspective. Now, if we're in a smaller practice, it's going to be important to at least have the input typically of it's usually a physician owner, for example, or a practitioner of some sort that owns the group. Then you have management, so an office manager, and then whoever it is that's handling coding, if they are coding and billing, sometimes that's the same person. So you may not have the same number of people coming to have the discussion, but it's important to do this because there's different things that, from the clinical side, for example, there's different reasons why our practitioners may want to utilize a new device or a new technique, or, use a lab that has new technology, things like that. And it's important to understand what it is that they are looking at and what they're wanting to do from the clinical side, but then we have to have those hard conversations about crosswalking it over to compliance for coding and billing. And that's where, Michelle, you had mentioned the challenging. I think that becomes even more important because I would rather challenges happen internally with people
Mhm.
getting frustrated and not wanting to hear what you have to say internally than if you're in a situation where you've gone years billing something and now you're looking at potentially having to, do your own internal investigation and self-report, or, unfortunately, sometimes people like to sit there and kind of wait like a sitting duck to see if they're going to get found out.
Yeah, and that's not the best way to approach that either. If you have the right people in the room to begin with, it doesn't have to be difficult, in my opinion. You have to be able to work together and know who has the ability to bring these things to fruition. So we can make policies all that we want. We can have the discussions, we can implement new, procedures or services, but we have to have the people in place and we have to have buy-in from them to enforce that policy essentially.
Mhm.
Um, because at the end of the day, you're going to have to come to some kind of agreement about what's going to work, what's going to be compliant, and what is going to work for the provider's workflow with implementing a new service, for example. So, when you create policies, it could be either because you're wanting to implement a new service, or maybe it's, an area you've done an internal review and you see a lot of issues surrounding. I'm going to use the example of copy and paste because that's a good one to have a
Hmm.
policy on. And if your facility doesn't have one, I highly recommend you implement a policy on use of copy and
A
paste.
policy that doesn't allow an entire note to be copy and
Yes.
pasted,
Yes.
because unfortunately those are out there.
They are, and I have recently experienced those. That's interesting, but that's a discussion for a different day for sure. Um, but it could be either, something, using a tool with your EMR system, a new service, how you're going to code something specifically. Um, but you're going to need people who can back you as you implement these policies, because sometimes we get those providers who I'm going to call them prima donnas. They think that they can do whatever they want because they're a doctor, and that your opinion doesn't matter because you're not a doctor. And I hate those situations because I try to approach things from a team player perspective. We are all on the same team. We all have the same goal at the end of the day, and that is for you to provide quality care to your patient and get paid for those services that you render. But unfortunately, sometimes we have those that are a little bit more difficult to follow the rules. So you need to make sure that you have the people in place that are going to help you to
Mhm.
put those policies into place and make sure that they're being followed and that the appropriate steps are being taken when they're not. So it's not just about policy creation, it's about also policy follow through. And usually, those people who are sitting at the table having those discussions about the policies you're going to create are the ones who have the ability to come behind you and back you as you're implementing these policies, and make sure that everybody is following the rules or have the appropriate steps in place when somebody is not.
Well, and it's important too because we can sit here and say all day long, this is what should happen. But we know in reality that there's a lot of things that play into decisions, but also very heavily into internal politics in
Mhm.
organizations. And, how many times have we dealt with people in administration that just cannot stand to quote unquote be wrong? It shouldn't
Mhm.
be a matter of wrong or right. It should be a matter of looking at the whole picture and understanding how that decision needs to be made. But, like you said, sometimes there are egos that come into play. Someone's in, a VP role or some kind of, C suite role, and they think that they're the end all be all because of who they are. And, that's going to create different challenges in itself. And one of the things that I like to do if I know that it's going to be a challenging situation. So, for example, a lot of times when I finish an audit review, a result of that is a need for change. And
Mhm.
it's not a bad thing, but it needs to be done. It's got to be dealt with, and it typically needs to be done pretty quickly. So, what I will do at times is have a conversation with the people that I'm working with on the audit project to say, okay, this is what this needs to look like. Now, let's pause for a minute and think about how that would be implemented. And as a part of that process, think through where your roadblocks are going to be. So, what I mean by that is what you've been saying, Michelle, if there's an individual person. Yeah, I know.
It's
It's
usually a
exhausting
person,
to think
okay?
about. Yeah, it's usually a person, but also I'm finding now that it's been a challenge with EMR companies as
Yeah.
well.
Yeah.
And that's really frustrating because there seems to be a lack of compliance knowledge inside of those organizations. And, as a entity, if you're purchasing a product to use it, you should have a say in what's going on from a compliance perspective.
Mhm.
So, you have to kind of map all of that out. And sometimes what you need to do, so in your example, Michelle, when you have a physician who's really difficult, or, a lot of times too, I'll find an entire department is difficult, right? A department
Mhm.
of practitioners. So a certain specialty is difficult. In that situation, talk with administration, make sure that they have a clear understanding. And to be clear, this is not coming to the table and saying, oh, we have this finding, it's a big deal, we have to change it, we have to do it now. Going with little to no evidence or no resources to back up your findings definitely should not be based on, one patient encounter. You
Yeah,
need
no.
to look into that issue, but get their buy-in and then have them help to bridge that gap. A lot of times, especially in hospital facilities, you will have clinical leads. So there will be typically a physician who's leading a specialty, and they do sit on both sides. Usually they have administrative roles and they have clinical roles. That is the purpose of, or one of the purposes of having somebody in a position like that, where we can go in and have the conversations and make sure that we're looking at all sides and that people don't just feel attacked or they're taking it
Hmm.
personally, and all of those human emotions that come into play, unfortunately.
Yeah, and I think that those emotions are unavoidable
Yeah.
when you're having some of these conversations, especially when we go in and we have audit results. Like, I know I just seemed to be a magnet for the situations when, we were having coding issues as a whole. My mistake was always the example. And in the EMR we used, you could go right in to to the billing side of things and see who did that. And everybody was doing that. So
Oh
there's
yeah.
there's going to be some emotions, whether it be from the clinical staff or even from within your own department. But like you said, you aren't basing these things on one-off findings. You're basing them on consistent issues that are found. So it's usually a difficult, road to navigate, to implement these things, to make sure that everybody is on board and everybody has an understanding of why this policy is necessary. And also give every single person at that table opportunity to give input towards what is in that policy. So like Stephanie said, there's going to be workflow processes from the clinical perspective. You can't just put this into play and not take into consideration how this is going to impact your provider's workflow. We all know our providers, it's something that I hear regularly. It doesn't seem like there's enough time for documentation. So a lot of times, these tools that are implemented in our EMRs, for example, I know we mentioned copy and paste, they're using that from a time saving perspective. Rarely do I see it being used from I'm just going to be lazy. I have golf today. I'm going to copy and paste this entire uh this
Hmm.
entire note so I can get out of here. No, that's not my typical case of finding. It's usually there's so much to be done that they're trying to find ways to cut down time on tasks such as documenting. But have input from everybody, have input from the providers themselves and how it's going to impact their workflow. Have input from finance, how is this going to impact us financially? Administration, they usually have opinions. uh, um, and then also from the compliance perspective. And when we're coming at things from the compliance perspective, I think sometimes we have blinders on, like, there is no other way we can accomplish this than by doing these specific things because we have to be compliant. So we really need that external input to kind of broaden our horizons a little and find a way that works for everybody and still remains compliant.
Yeah, and one of the hardest things or the hardest ways to tackle this is when you're having to backtrack everything.
Hmm.
And it makes me think about a situation I dealt with last year where I go in to do a routine review and they had some potential concerns. But what I started to unearth when I was in there was the fact that the practitioners were largely prescribing weight loss medications that were not FDA approved. So a lot of the findings were not favorable by any means. So bringing it back into the people who requested the audit, I very quickly find out that it's a larger problem because somebody in the compliance department, which was separated, had helped to do research prior to them even beginning this service. Then, in addition to that, there was a huge issue because you have multiple patients who are now receiving services being billed incorrectly to the insurance, and they want to continue their treatment. You can't just medically abandon a patient, which has to be thought of clinically. Then we also have the situation of outside practices knowing that this service was now offered and them constantly funneling in and referring patients in
Mhm.
specifically for that service. So, there were so many times in, I would say, about that 4 week period after the initial review of the audit information and meeting with the providers that I had to continually go back and reiterate with the people I was working on the project with what those sources were, because the more people that found that out in administration in that hospital, they do not want to make the change. They
Yeah.
don't want the patients to be mad. They're going to start asking questions. Well, what do we do to get this covered? And the answer is it's not always going to be covered, and that's
Yeah.
not the way that it works. So that's another thing. It's really important to have people, and it really should be a part of your ongoing compliance program, but we know that's a problem as well. But you should have people from these different perspectives that are meeting at least on a quarterly basis so that you can talk about new things that are being done, maybe requests that providers have. In my experience in the past, it's not something where a physician says, "Oh, I would like to offer this service. I need these devices," and they just go and buy it with nobody anywhere knowing about it, right?
Mhm.
There's usually a process in a
Yeah.
facility. Obviously, if it's a smaller group and they're an owner, then yeah, they're going to do it. But you can see changes, whether it's typically in billing patterns, maybe there's a new
Mhm.
code you've never seen, things like that. So there's ways to look into this if you feel you're limited from the perspective of who you have to go over this with. But it's important to be proactive because going back
Mhm.
retrospectively is just a nightmare.
It
And
is.
it often involves needing an internal investigation, potentially self-reporting, all of those things.
Yeah, and it makes me think about those facilities who don't employ coders. They want the providers to do all the coding themselves. And that is something where you still have to have a department in place to be doing some kind of review that there's checks and balances to these things, because so many times, like you said, providers, they have, groups of physicians that they chat with and they get together with, or they go to these
Or their
conferences.
friend down the road.
Yes, and they're always like, "Oh, well, Doctor so and so told me they're doing this and they're getting paid for it. So I just decided to start doing it." And it's like, "Well, Doctor so and so is wrong. They may be getting paid. Remember, payment does not equal compliance. Just means nobody's looked at it yet."
Yeah.
Is typically the situation in this scenario. Or the provider has heard this, billing tip at a conference. I remember I had a rheumatologist come back from a conference and was like, "I should be billing for telephone calls." Now, this is pre-COVID. And they were convinced that they should be billing for telephone calls. Now, granted, this rheumatologist also thought that they should get some kind of bonus for referring their patients to the infusion center because the drugs that they uh, prescribe are extremely expensive. But just to give you an idea of what we were dealing with, they had
Sounds
gone to
like they
this
need an
conference
attorney.
and come to find out this code that they were referring to was only paid by one payer. So I brought them the payer mix and I'm trying to think of a solution, like, you know, knowing the situation, I wanted to be able to say, well, we can't do this, but we can do that. But in reality, we couldn't do what this provider wanted to do at all. So, they had gone to this conference and come back with this nugget of knowledge that they could now bill for all their telephone calls. And then it turned into their medical assistant billing for their medical assistant's telephone calls and trying to
Mm.
find all of these ways to get extra revenue. And it's like, you can't do that. You need to just continue what you're doing. I don't know what to tell you. At that particular facility, the infusions were done through the hospital, so it's not like the rheumatology department saw revenue from that. So it was really based on their E&Ms. But, it's like you've got to have those things in place that you're watching for those strange codes that start coming through. Um, part of my role at that hospital was to, on a monthly basis, do a review, make sure that charge capture was happening correctly, that we weren't having preventable denials. So even though we did have a coding staff, but we did have quite a bit of staff dedicated to making sure what was going out the door was correct. Um, so there we didn't have 100% review. The providers were mainly responsible to select their own billing codes, and unless it hit an edit in the system, it really wasn't reviewed by a coding staff member. So they relied on us, the ones who on a monthly basis were tasked with overseeing the different revenue and stuff from the departments. So make sure you have those processes in place that you can pick out these things that are happening and identify the problems.
Yeah. Yeah, absolutely. And, it's one of those things too where if they want to have that financial discussion, then talk about what it could look like in the future.
Hmm.
There's a lot of times they want to see the here and now, especially now where there's, reduced reimbursement, things like that, or, cost expenses are going up, but reimbursement is not. This is
Yeah.
not the solution. And
Mm-mm.
you can do these things compliantly, but you need to think through the different avenues and different services that you want to implement. And then from there, have the conversations, create a policy around that, and come at that from an educated standpoint from all angles and not just
Hmm.
one perspective.
Yeah, and I think it also relies on a heavy understanding of medical necessity. So just because something can be billed doesn't mean it should always be billed. It may not be medically necessary. And something that comes to my mind, this is just an example of something that I dealt with recently, was billing the annual wellness visit along with the preventive exam. Every single annual wellness visit had a preventive exam, and it was like, was it necessary? You had to
Yeah.
look at the documentation. So just because this payer will pay both, one, did you have documentation to support both services? And was it was it really medically necessary? Was that the intent of the visit, or is it just a revenue grab? And
Mhm.
that's something to think about. Yes, we need to have payment for the services, but is it always going to be necessary to bill it?
Yeah. All right. Now, Michelle and I were talking. We wanted to implement a new segment at the very end of each episode just to kind of lighten things up. A lot of times right now, a lot of people are feeling kind of heavy within the industry, whether it's with the workload, the stress. There's a lot of people out there too that are, unfortunately losing positions, looking for new jobs, different things like that. And there's just a lot going on that can really add a lot of stress. So we want to lighten some things up, even though we're focusing on compliance, which, we can joke is not everybody's favorite subject.
No.
But there's a lot of things that happen in our days that we can laugh about, right? So,
Yes.
Michelle, why don't you go ahead with your lovely moment and
Well,
experience related to what the health?
and one thing that I want to say is, one thing that Stephanie and I really are good at doing is laughing at ourselves, because we are really good, whether it be work related or just in our personal life, we are really great at creating these awkward or hilarious moments for ourselves where we are like, what the heck just happened? Or what were we thinking? um But today's awkward moment is brought to you by slippery floors and my overconfidence apparently in my dress shoes. But luckily this didn't happen in front of anybody. However, it happened about 2 seconds before I was supposed to go do some training for a group of hospitalists. I had traveled to a local hospital. This was during COVID time, actually. So we hadn't dressed up like this in a while. We'd all been working from home. But I met with the practice manager in the lobby and asked to use the restroom quickly before we went to go meet with the hospitalists, where I promptly apparently, like I said, was overconfident in my shoes and did a complete split and somehow had to figure out how to get myself up off the floor and walk composed into this room of physicians and proceed to do an hour-long training. All the while, I had just basically dislocated my hip socket. So as you can imagine, that was an interesting situation. And something people don't know about us is we tend to laugh in the awkward moments. So not only did I have to figure out how to get my legs to work again, I had to figure out how to not laugh at myself for the next hour every time I thought about myself doing this full split in the bathroom. Just minutes before. So yeah, I mean, we all have those embarrassing moments. Thank goodness mine didn't happen in front of anybody, because I know Lord knows we've all face planted it at the wrong time and popped right up and said, who saw that? But yeah, so we invite you to share your awkward stories with us. You can stay anonymous or allow us to share, who it's from, but we want to encourage some comedy in our day-to-day lives, and know that we can laugh at ourselves even if we have bad encounters. Like, I know I've had some interesting encounters where after the fact I'm like, maybe that could have gone better. But what did you take away from the circumstance? How did it help you better yourself in the end? I don't know that doing a split in the bathroom has any life lessons other than wear shoes with better traction.
Well, it's good to laugh at yourself. We talked
is.
about the people who think they're perfect and always have to be right, and that's very humbling when we go through these things. And like you said, we our first reaction, whether it's sad or anger involved or whatever it may be, we tend to be sarcastic and laugh. So it
Yeah.
can help you get through things, but also learn.
Yeah, so we'll definitely be sharing our awkward moments. They likely won't be related to the topics that we're talking about, bonus if they are, but it's just something to kind of humanize us as
Mhm.
people and what we do.
Yeah, and have some fun.
Yes.
All right. Well, thank you for joining us this week. Next week, we're going to come back with another episode finishing out this series related to policies. So we hope to see you back next week.